further, it is because I stood on the shoulders of giants. And this panel just was a real manifestation of that statement. Without further ado, we are going to move on to the last item of today's agenda. I see this with a lot of nostalgia in me already. I can't believe that TORG 2025 is already coming to an end. So we are going to have an oral abstract presentation, which is the last item on our agenda for today and for this conference. This oral presentation is going to be done by, I think, Demeke Yilkal. Are you here? Dr. Demeke Yilkal Fentie. Are you with us?
Yes, I'm just here.
Okay, great. So I'm going to introduce Dr. Demeke to you all and hand over the floor to him. So Dr. Demeke is an assistant professor and chief anesthetist and specialist at the University of Gondar in Ethiopia. With over 12 years of experience in anesthesia and critical care, he has authored more than 30 publications and serves as the executive board of the Ethiopian Association of Anesthetists. His work focuses on advancing anesthesia education, patient safety, and perioperative care. So before handing over the floor to Dr. Demeke, I'll give you all that if you have a question, kindly write it down or drop it in the chat box so that we can discuss it later. Dr. Demeke, the floor is yours. You have 10 minutes.
Okay, thank you. Is it audible for all you guys? Okay, thank you. So, good morning, good afternoon, and good evening for everyone. So, I'm going to present one of my research findings. Actually, this is part of a big project, which is exploring the challenges and lessons learned from mass casualty management and response, qualitative phenomenological study design, which is done at University of Gondar Comprehensive and Specialized Referral Hospital. So University of Gondar Comprehensive Specialized Hospital is found in the northwest Ethiopia, and it is one of the oldest teaching and research university hospital in the northern West Ethiopia, serving more than 13 million of people in that area. And it has more than 1,000 beds with different specialties like surgical specialty, pediatrics, maternal and child health, oncology center, ICU, emergency and critical care center, and the like. So after saying this about University of Gondar, a specialized hospital, I'm just going to do my presentation. So this phenomenological study actually intends to explore and understand the perception of the lived experience of the caregivers while they try to manage mass casualty. So, as part of an outline, we have introduction, methods, results, and discussion together, and then conclusion and recommendation will follow. So, to keep time, mass casualty situation, and as you know, during mass casualty, there are unexpected things happening because of because of the arrival of large number of injured victims, often as a result that exceeds the capacity of the healthcare institution, which can indeed lead to a major cost and crowding, which is actually evidenced by research. So a wide range of events, including natural and man-made disaster, terrorist attacks, car accidents, military battles, and all these occurrences may result in large gatherings, can result in mass casualty situation. So managing this casualty incident is really more difficult, and medical response need to be investigated more from crisis management standpoint. The University of Gondar Hospital has witnessed and received series of civil crises that have generated mass casualty because of different reasons. So this study explored the healthcare lived experience and perceptions regarding the challenges and lessons learned from the casualty response at University of Gondar Comprehensive Specialized Hospital in 2023. So the methodology, the study setting is University of Gondar Comprehensive Specialized Hospital, sample size and participants. We purposely select 17 healthcare professionals, especially senior nurses and administrator leaders. Sampling, we use just a purpose sampling technique, and in-depth interview and key informant interview were undergone, and the thematic and sub-theme analysis also was undergone. So data analysis procedure, as you see, the transcription, translation, and formalization, coding, and categorizing of themes and sub-themes were carried out throughout our research project. So the result in the discussion, social demographic characteristics of participants. We interviewed 17 healthcare professionals, age ranging 42, and 64% of the participants were nurses, and 35.29% of the participants were BSc degree holders. And when you see work experience, the minimum work experience was 1.5 years, and the maximum was 14 years of experience. And themes and sub-themes emerging from the study, there are about 5 themes and more sub-theme areas. So the management and response preparedness, experience during mass casualty management, challenges and perceived impact of the casual incident, and suggestions future improvement about mass casualty management response were the themes. And there are plenty of sub-themes, including assessing the system readiness, enabler factors, and also resource-related and system-related challenges were analyzed and assessed. Health-related impacts, including socio-economic impact of the mass casualty to a certain healthcare setting, emotional and psychological impact, capacity building, surgery capacity, prevention and mitigation strategy were assessed during our research project period. When you see the result in the discussion, as it is a qualitative research, just gonna to present the translated and transcribed data from the respondent. So one of the respondents, which is represented by RSHP point 1, responded that mass casualty events have become increasingly common in Ethiopia, especially over the past 3 years, with notable surges since 2008 during the northern part war in Ethiopia. During the conflict in the north region, the hospital received more than 400 wounded patients or militants simultaneously. A bridge collapsed during the Epiphany celebration in Gondar, resulting in approximately 450 injuries, overwhelming the hospital capacity. And targeted attack during the funeral ceremony also brought in around 80 critically injured patients to the hospital once, and this leads to overcrowding of the intensive care unit and emergency wards. On average, 3 to 4 mass casualty deaths occur each year, putting sustained pressure on emergency medical service in our hospital. And this study verified that the hospital has not a prepared plan before mass casualty regarding with protocol, guidelines, and resources. However, there were on-site training for the healthcare providers. And the research evidence showed that healthcare professional must know the facilities plan, and multiple individuals on all shifts must have the skills and the knowledge they need to lead the response, and the hospital must prepare to resource medical supply and drug stores. So our hospital were in trouble of arraying disease. As a team leader, because our participants were clinical leaders, we didn't plan because we didn't expect such occurrence, and they did have such a capacity to manage more than 400 casualties simultaneously as a time. Mass casualty management lacked organization and structure. Departments were mobilized reactively based on the scale of the incident rather than coordinated plans. So reliance on existing human resources without strategic allocation due to imbalance between available resources and patient influx. Supplies and equipment were not replenished promptly due to bureaucratic delays, forcing the staffs to operate within limited resources. Overburdened hospital staff struggle to manage the hospital patient load, resulting in delay, suboptimal treatment, especially as the primary level facility were not utilized or underutilized. And the management of mass casualty was not organized and structured, but when accident occurred, each department was called to deal with the damage according to the extent of the damage, including the medicine pediatric sites. Even dermatologists and other healthcare professionals were invited to manage patients. It is a traditional system that we used to deal with it. And they don't believe that there is committee to organize or coordinate mass casualty incident. Therefore, it was managed by the traditional method. This is the response of the interview. And this study also revealed that the hospital has adequate manpower. However, lack of supply and basic equipment, financial resource and infrastructure were one of the major challenges to give standard service. In general, there were many problems due to the large number of people victims, and there was material shortage, narrowing of the wards. Generally, patients were treated in tents and on the floor as there were not enough beds. And the need to strengthen the four key components: human resource, material resource, structure, and system, shown by the surge capacity of the health system, will lead to optimization of the mass casualty incident management in any settings. In the study, participants reported that there were communication gaps, delay in patient transfer, lack of coordination, command and alarming system problems, transport problem, and delay in investigation service system related challenge during mass casualty management and response. On the other hand, no one communicates from the place where it happened, which is a big problem for the management of this casualty in University of Gondar Hospital. If a disaster suddenly happened, the hospital should have way of communication, and the bystander should notify the hospital. But during that time, there was lack of bystanders, lack of communication from the incident site, and resulting in poor preparation and delay management. Participants perceive the impact of mass casualty incidents, exhibit a wide variety of related problems. This includes disruption of normal medical service, including cancellation of elective surgeries, worsening of chronic illness, notably among cancer patients. OPD was closed and suspicion of community health service, where their high staff turnover and low morale due to emotional and psychological stress were there. Economic strain on the community and significant budget impact also was the perceived impact of the mass casualty incident. And in terms of backlog and waiting time, the waiting time and the backlog were increased during the mass casualty time, and the cost of health coverage, especially those who want to pay and gain care in private hospital, was the result of catastrophic expenditure, even greater than out-of-pocket expenditure. They expend by borrowing from neighbors and other relatives. So they will result in catastrophic expenditure, which is not the. So this study looked at various problems that come with mass casualty events: lack of readiness, coordination, collaboration, and communication, as well as lack of prevention and mitigation strategy, where the was one of the incidents or the finding. The casualty happened previously give a lesson for the future prevention is that hospital linkage to district and primary health care center is very important. Integration of teams, emergency drill preparation, training, capacity building, digitalization, dispatch center with ambulance care service are mandatory for the management of incidents or mass casualty, like which was happened in the University of Gondar. So the key issues in mass casualty management will overwhelm medical resource, breakdown in communication and coordination, adequate triage system will be there, logistic bottlenecking, emotional and cognitive overload will be there. So to overcome this, we need to have hospital linkage, we need to prepare, we need to have integrated system, and we need to have dispatch center with ambulance. This is what I have. I think I ran faster for the sake of time. Thank you very much for listening to me. And this is all what I have. Thank you.
Okay. Thank you so much, Dr. Demeke, for that wonderful presentation. Is there anyone who would like to ask a question before we proceed? Any questions?